Yo, yo, yo. Hey, guys, welcome back to another amazing edition of the Best Practices Show podcast. This concept, centric relation, is it confusing? Well, it is for a lot of dentists. And sometimes we don't think correctly about it. Well, today I bring back a great friend, regular mentor to the podcast. His name is Dr. Jim McKee, and he shares with us the biggest misconceptions about centric relation every dentist needs to know. It is awesome. So please listen up. I hope you guys enjoy this, and we'll see you soon. Hey guys, welcome back to the Best Practices Show podcast. I have the greatest job in the world. You know why? Because I get to take CE for a living and I get to bring you guys with me on something called the Best Practices Show podcast, where I pull in friends of mine, teachers, leaders, mentors, great minds in dentistry to share some great thoughts to help you create a better practice and a better life. And today is no exception. I have one of my favorite of all time, Dr. Jim McKee, and he is back today to share some great thoughts around this thing called CR, centric relation. What is centric relation? Why is it misunderstood? And a whole bunch of other thoughts. Jim, thanks for being back, brother. I always appreciate you.
Kirk, it's always a highlight to be with you. So thank you so much for the invitation. I look forward to every one of these. It's been a great time doing these.
Yeah. And I know by the metrics people are watching. If you haven't listened to the most recent one, I was telling Jim before we hit the go button, 750 episodes. We went back and looked at some of our favorite episodes, some of them with the largest number of downloads of all time. One of them in particular was called the Restorative Diagnostic Practice. Now, I've listened to that one 5 times. And the reason I've done that 5 times is Jim describes the future opportunity for dentists in 3 different buckets, and why the restorative diagnostic practice is such an important, viable solution if you can see it correctly. And I really believe this, Jim. Nobody's better to explain that than you. So I'm so grateful, and we're going to cover a whole bunch of other subjects, but let's start here.
Well, thanks, Kirk.
I'm so pumped. This could be a 2-hour podcast. So let's go into centric relation. I always like to start here. Why is this such a hot topic?
You know, typically when people talk about centric relation, eyes kind of glaze over, because I don't know if there's a more confusing term in dentistry than centric relation. So when people say, what is centric relation? I think primarily it's misunderstood. It's misunderstood. We haven't helped ourselves. We've kind of shot ourselves in the foot. When you look at the glossary of prosthodontic terms, there's 9 or 10 different definitions of it. And none of them really relate to a regular, everyday dentist. So let's start out by making it really easy. What's centric relation? Centric relation is no more, no less than normal joints fitting in normal joint sockets. That's all it is. It's nothing mystical. It's not a crazy concept. It's an anatomic position is what it is. Now, you'll note I said normal joints fitting in normal joint sockets. That means a normal disc is on top of a normal bone fitting into a normal joint socket. Now, that sounds pretty logical, but part of the problem is a lot of times we're dealing with patients who may not have normal joint anatomy, and therefore the system may not work the way it's supposed to. Typically, when we talk about centric relation, what we do is we talk about if we were able to get the condyle fully seated in the joint socket. Because that we always think about it as a positional discussion. Did I achieve a fully seated condylar position? And if you did, you were a good dentist. And if you didn't, you were a bad dentist. You had to have the scarlet, CR on your chest because you couldn't get it. The problem is, the reality is, most of those cases that you couldn't get, it probably wasn't possible to achieve because we didn't have normal joints fitting in normal joint sockets. If that's the case, it's not that you're a bad dentist. It's not that centric relation is even the right position to be thinking about. It simply tells us there's anatomic changes in the joint. And as a restorative dentist, I want to understand that from a treatment planning perspective, because it's going to change the way I frame the patient's expectations. That's really, I think, the easiest way to start the conversation. And, I kind of tried to think how I was going to talk about this today because, as soon as you bring this topic up, dentists really get crazy because there's been so much misunderstanding about it. But, it's interesting. When I got out of dental school, most of the prosthodontists around me and most of the really good restorative dentists around me used centric relation. And I had no understanding why. I never used it in dental school. I understood what it was to pass the test. But once I got out, the first 2, 3, 4 years, never even thought about it. In fact, thought it really doesn't make sense. Because if you do check the bite and centric relation, what happens is most of the time, the back teeth touch and the front teeth don't. So Pete Dawson talked about that for years. So then you're like, okay, what do I do now? Now I've got a bite that doesn't fit. I'm not going to pay any attention to that stuff. I'm just going to build a bite where the teeth fit together and want to call it a day. And fortunately, for a lot of patients, maybe most of the patients, that works. Most of the patients, not all of them, but a lot of them, it works. So I understand why most dentists really don't have an interest in this and don't think it's a really important topic. But let's go at it from a different perspective. Because really, if you think about why the good restorative dentists and the prosthodontist and a lot of the giants in dentistry that have come down over the years, who have been some of our best educators, have advocated using centric relation, is because it does have advantages. The primary advantage of centric relation is twofold. Number one, if the disc is on top of the condyle and it's attached at the medial and lateral pole like a bucket handle, that gives us a soft tissue cushion between the condyle and the joint socket. Ultimately, the purpose of one of the functions of the joint, let's put it that way, is to help dissipate the load that's generated when we bite down. Now, here's when I started to realize that maybe I start to take a look at centric relation a little bit more carefully. You know what it was?
What?
When the restorations I put in on the back teeth started to break.
Yeah.
I mean, really, what I was doing is I was building into a potentially unstable environment, but I had no idea about that. So I ended up, and I have to credit Pete Dawson on this because Pete's really the one that opened my eyes to this many years ago. If we can look at the joint as a force distribution unit, and we can look at the teeth as another force distribution unit, now we can split the force between the front and the back end of the system, and maybe all the porcelain that I just put in isn't going to break now. So for me, it became really a point of dissipating the load that the patient was generating.
Right.
That's really what it came down for. That's the first thing. The second thing, what I started to notice is patients would have different bites sometimes. Sometimes they'd bite on this side, sometimes they'd bite on that side. If they had a disc, which here's the way to think about a disc, and this is the way I explain it to patients. Think about the disc as a gasket. That's a soft material between two harder surfaces. Basically, I say, think of the plastic molding on the inside of your refrigerator door that keeps the cold air in your refrigerator. That's a gasket. A soft material between two harder surfaces. That's basically what the disc is. It's a three-dimensional gasket that positions the condyle in space in a repeatable position. So now I have a bite that can be repeatable, and I can give my technician enough information, or if I'm digital, I can scan that in a condylar position now that allows me to build with the most effective load distribution position and a repeatable position. When you look at it that way, what that does, that takes most of the risk out of the treatment planning for restorative cases. Now, the only other thing I have to do besides that is to make sure that the front teeth aren't in the way of where the lower jaw is moving, which is anterior guidance, which is the second thing we talk about after we determine where we're going to build the case.
Right.
So really, centric relation is important in those types of cases because it allows a restorative dentist complete confidence. If I have a case where I know I have the disc where it's supposed to be, I'm 100% confident that I can get a result. Now, all right, let me rephrase that. I'm 99% confident that I can get a result that's going to be predictable and it's going to be comfortable.
Right.
Now, there's always patients who will break the rules, and I get that. But for the most part, and I was lucky because Pete really influenced me early in my career. So I've almost exclusively worked in a fully seated condylar position my entire career. You'll note I didn't say centric relation because fully seated condylar position and centric relation are two different things. Centric relation means normal joints and normal joint sockets. A fully seated condylar position means the condyle is as high in the joint socket as it can go. The difference is we're not talking about soft tissue. So a fully seated condylar position may be centric relation if the gasket is in the right place, but if it's not in the right place, then it's not centric relation. And therefore, maybe we don't think about using centric relation if the disc isn't in the right place. Now, here's where I step out of the way because this is where Pete's going to hit the lightning bolts down on me. Because I was always taught, and I think as this was generally taught in most teaching centers, because really, if you look at most of the teaching centers, whether it was Dawson, whether it's Pankey, whether it's Spear, whether it's Coyce, whether it's LVI, generally what those teaching centers are teaching centers that are teaching advanced prosthodontic techniques to general dentists. That's really what it is. We got as much as we could in dental school, but dental school had all they could teach us to prep teeth and hopefully get an impression where you could get a crown that fit reasonably.
Right.
The nuances or the sophisticated discussion really occurs in postgraduate education. And all those teaching centers have had fabulous teachers teach there. But again, I think everyone has pushed the joint to the side. I have to credit Mark Piper for the one that really opened my eyes on this because Mark was the first person that I heard talk about an MRI. Never even thought about an MRI, never knew what an MRI was. Well, what an MRI does, it gives us the opportunity to see if we have normal joints in a normal joint socket. CBCT can't tell us that because we don't know where the disc is with a CBCT. We can guess, but if I'm going to do a full mouth rehab on a patient, and maybe it's not going to be all at once, maybe that's going to be 4 crowns a year. Even more important in that case, because I'm going to have to phase that out over 3, 4, 5 years. I want to start with the back end of the system where I want it to be. If it's centric relation, great. If it's not, okay, that means I don't have normal joints and normal joint sockets. That means I'm going to talk to the patient differently. It also means that I may build the case differently. But ultimately, that's what I want to know. Because if I have it, I'm completely confident. If I'm not, then I have to reframe the patient's expectations. Does that make sense?
It does. It does. And so one of the questions comes up, okay, do we have to use CR for everybody?
That's one of the biggest confusions in this topic because, you know, I was called a CR zealot by a very prominent teaching instructor once.
Whoa.
And it wasn't that I was a CR zealot, but I saw the advantages of centric relation. Now, does that mean you use it on everyone? No, because the reality is sometimes you can't use it on people because it's not possible to achieve.
Right.
If I have a patient that has a clicking joint, I can't get centric relation. I don't have a normal joint. So that takes the discussion right out of the system. Then my discussion is, okay, where do I want to build where do I want to have the teeth fit together? Where do I want the condyle to be when the teeth fit together? If you've got a disc at the top end of the system, that makes it easy. Then you can have bracing at the top end on the right, bracing at the top end on the left, and all the teeth fitting together. It's like a three-legged stool. It's almost impossible to have a problem in that type of situation. If I don't have that, however, that's when I want to start thinking about talking to the patient differently. And ultimately, if I don't have that, I can't use CR in everyone. Part of the reason why centric relation got a bad name is because people thought they were treating the centric relation and they're jamming the condyles up with no soft tissue protection, and patients didn't do well with that. It really wasn't centric relation. It was a superior condylar position, but it didn't have the soft tissue protection that's inherent in the definition of centric relation. So centric relation took a lot of bad raps when really it wasn't true centric relation. Now, I want to be really clear. If the disc isn't there, then you don't have to build in a superior position. And if the disc is there, you still don't have to build in a superior position. I think it makes it easier because I think everything goes to a certain place and it fits there and it stays there. The cases I'd be careful about because people say, I don't want to use this. I'll just use it on some people.
Right.
So who are the people? Well, think about it this way. It's the people that I need maximum load distribution on. So who are the people in our practice who have proven that they overload their teeth? The most common one comes to mind is a wear patient. A lot of times dentists think that patients who grind their teeth have problems at the jaw joint level. That's not been my experience. Usually what I've seen is teeth wear out on the front end of the system. Well, actually, the back end of the system stays in pretty good shape. So if I have a wear case, if I can verify that I have a disc in the right position, I'm going to build that in centric relation every day of the week. Now I just have to make sure that my front teeth aren't too steep, so I'm not bumping into them or they're not in the way as I'm moving, one or the other. Depending if you go outside in or inside out, I'll use both and check the bite in all different directions. But if we can get the back end of the system to fit at the joint level, get the front end of the system to fit at the tooth level, in a wear case, that's going to be the most predictable way to distribute the load.
Right.
So a wear case might be one example. Another might be, we do a lot of implant reconstruction today, and implants don't have the same properties as natural teeth. Natural teeth have a little bit of give. Implants are rock solid in the bone. They have 8 microns of movement where natural teeth may have 25. So, there's some difference, but you don't have the same forgiveness with implants as you might with natural teeth. So in that situation, again, I'm going to tend to try to build that in a centric relation position if the disc is there, so I can use the back end of the system to distribute the load as best as possible and maybe leave the occlusion relatively light on the implant restorative work. Now, teeth have to touch enough to distribute the load, so you can't leave it too light, but those might be 2 examples from a load distribution I want to do it for. Let's go to the other side, which would be occlusal stability. Well, the question that always comes up is the patient comes in and they broke number 18, their lower left second molar. Well, a lot of times the second molar is the first tooth that touches when you seat the joints in the joint socket. If that's the case, then you got a decision. Am I going to try and build that back in to where it was if it was the initial point of contact, precisely so it fits together, which is almost impossible? Or am I just going to build it forward into the natural bite? Most of the time we choose to build it forward into the natural bite, but that's the case where you prep the tooth and all of a sudden you start to make the temporary and you don't have enough room because the bite started to shift because that tooth was actually holding the mandible in a certain position. When that broke, the bite shifted, and now we don't have enough room to prep the teeth. So in terms of or in terms of occlusal stability, I might want to think about adjusting the bite now so I can get an even bite to build a crown back to. So I might think about that. I guess the other thing is, I guess the more dentistry I do in the mouth, the less willing I am not to have it in a fully seated condylar position or centric relation if I've got the disc there. Now, we haven't talked about what to do if the disc isn't in the right position. So why don't we touch on that for a second? How about that?
Let's do it.
All right. So the only way to know definitively where the disc is with an MRI. People used to say, you really don't need an MRI to treat the case. I'm going to respectfully disagree. In my experience, if the gasket isn't at the medial pole, lateral pole's the outside, that's the part you feel when you open and close. Medial's 20 millimeters in towards the brain. That's the load-bearing part of the joint. That's also the part of the joint that maintains the vertical dimension. And the soft tissue is what really maintains the vertical dimension. If that's gone and the condyle repositions, the bite's going to shift. So if that's the case, how do we look at those patients then? The MRI will show us where the disc is. Piper's protocol looks at 4 condylar positions. Fully seated, that means a superior condylar position. Natural bite, maybe hitting and shifting forward a little bit. Incisal edge position, so we can see the position of the disc in the functional position when patients are out on their front teeth, and then open. So we look at the disc fully seated, maximum intercuspation, natural bite, incisal edge position, or if it's a growing patient and they have a click or a pop, we might be thinking about making a bite appliance that brings them forward to get under the disc. That might be made more at the class 1 canine position. That would be called a functional appliance, something like a Herbst appliance, something that many times is inserted and it's a fixed restoration. You can make them removable too. Compliance becomes a little bit more of an issue with that. But what we're trying to do for the growing patient is reposition the condyle disc interface to help the bone grow as much as possible. But those would be the thoughts that I'd be thinking about in terms of the MRI, and then open tells us if we can get back underneath it at all. So Mark's rule was build your case the least forward that you can, making sure that the disc is covering the medial pole. So let me say it a different way. If the medial pole is covering the disc and fully seated, that's going to give you maximum load distribution. That's going to give you maximum occlusal stability. If you need that, use it. If you don't, don't. If you build in maximum intercuspation and you have coverage at the medial pole, great. You have to know that if you go back, you might hit on the back teeth, so you have to let the patient know that. But you're going to try and position that bone underneath the disc and try and get maximum protection. Now, if you don't get back under the disc until you're all the way out edge to edge, then you got a discussion. Because you can't build someone out edge to edge. So what that means is either they're going to be built off the disc or you're going to change the joint anatomy. You're either going to try and repair the disc, reattach it so it fits normally, Or if it doesn't have any chance of doing that because the grape has gone to the raisin, the disc is dried out, you're going to take the disc out, you'll put abdominal fat in and use that as a replacement. Now, most of the time, people don't do that. So generally what we do is we build the best we can and try and get things to fit. And if we're lucky, it works. And if we're not, those are the patients who keep calling the practice and says, I can't get my bite to fit together. And you come in and you check their bite, doesn't fit. And you check their bite and you start grinding. And, 45 minutes later, you're sweating, the patient's sweating. The new work that you just put in is all ground through now. Tough day at the office.
Yeah. So many questions. I have literally 20 questions here. Give us some of the disadvantages of not being able to achieve centric relation.
Well, if you don't have the disc there, you're always hoping for the best.
Right.
Then it really comes down to bone volume. If you've got good bone volume, you got a shot. Good bone volume means the bone's going to fill at least 2/3 of the joint socket, not a skinny condyle. Those are kind of like wearing high heels in wet grass. It sinks through there. Right. So I've been told. I don't do the visual, Kirk.
Right.
But that becomes the next question. What's the condition of the bone? If the bone's good, build a case. Let the patient know we don't have soft tissue coverage. We're going to assume you're stable until you prove us otherwise. That was a great Mark Piper line. We're going to assume you're stable until you prove us otherwise.
Right.
And then we're going to build a case. Whether it's a splint, whether it's an equilibration, whether it's orthodontics, whether it's an aesthetic case, whether it's orthognathic surgery. The only issue becomes airway. Airway always throws a monkey into the wrench because now we have to make a decision. Are we going to move the jaw forward with potentially compromised anatomy to help potentially change airway anatomy? And if we do, how is that going to impact the joint?
Right.
Those are the hard questions. Mm-hmm. And how far do we have to move them forward to have it work?
Right.
And does it work?
Right.
I mean, all those questions become difficult now. And as a practitioner today, you find yourself with 1 foot on each side of the river, and the river's getting wider, and you're not sure which side to jump onto. You know what I mean?
Right.
My point is, I think you have to look at everything. And I think a lot of the airway patients that we see today, in fact, I know this is the case, especially the ones that have compressed pharyngeal airway space, many times didn't grow well, and those are the ones that have the short ramus lengths, and the lower jaw can't project out far enough, so invariably they're going to compress the pharyngeal anatomy at the airway system. I have tons of cases I show on that in lecture, and I think today to do airway, you have to be able to do joints.
Right.
So that becomes a discussion about what you do if you don't have it.
Right.
Ultimately, if you don't have it, though, the first thing you have to do is to verify that you don't have it, which means you got to image.
Mm-hmm.
We always jump to dessert before we eat the vegetables. We go to treatment before we go to diagnosis.
Right.
If you notice, we've all we've done is talk about treatment.
Mm-hmm.
The diagnosis is what the first step of treatment planning is.
Yeah.
We can't come up with a treatment plan until we know the back end of the system.
Right.
I can't make a sleep appliance until I know the back end of the system. I can't do ortho until I know the back end of the system. I can't do restorative.
Right.
I can, and I can guess, and I can hope I'm lucky. But, I did that in the early years till I met fabulous teachers who steered me on another track.
Yeah.
I saw my friends who have practiced an entire career now, who never really were fortunate enough to have that guidance. They never enjoyed dentistry. They never felt confident doing the more complicated cases. It was an exercise in frustration for a lot of years. Really, the benefit of understanding these concepts that we're talking about, centric relation, fully seated condylar position, really comes down to predictability and restorative dentistry.
Mm-hmm.
And that is on a day-to-day basis what keeps dentists up at night, burning stomach lining.
Yeah. And speak to this too. I'm going to totally butcher who said this, but I think it was Dr. Amsterdam who said, while there are many treatments, there's only one true diagnosis.
You hit it, you nailed it. That's exactly what he said. Here's the problem. We've ignored the soft tissue in this joint. If you look at us, if you look at dentistry historically as a profession, what we've done is we've imaged hard tissue at the joint level, transcranials, panorexes, CBCTs. We've ignored soft tissue because some patients click and they don't hurt. And we have made this about pain. The problem is when you talk about TMD and you talk about pain, by the time they have pain, it's almost for sure there's already been some type of malocclusion, whether it's big or small. But there's some type of bite shift that has occurred because by the time tissues hurt, usually the soft tissue is gone and you may have had a change in the bite. You're going to have a change in the bite as well.
Right.
Now, I'm not saying you can't have pain with the soft tissue in place, but that's usually a different type of pain that's typically described as TMD pain. That's more muscle pain. On a scale of 10, that's a 1, 2, or a 3. I'm talking about people who come in with a 6, 7, 8, 9, and we think we're going to make it get better if we change their bite.
Right.
Most of the time, there's a joint problem there.
Yeah.
So that's why a lot of times if we treat the centric, what we're thinking is centric relation, and we seat the condyles, and it's got an eroded superior surface, because if you think of the condyle like an M&M, a hard shell outside and a soft inside, if the hard shell is cracked and we're loading against that, and it doesn't feel good, and we build a bite to that, and then we get the front teeth real tight because we want the front teeth to contact and the back teeth to separate, because that's what we were taught. Those are the patients that go crazy.
Right. And we've had Drew on here. Go back to that. Why don't you go back to that? Sometimes we think we're working with normal joints, and these are injured joints, which requires better questions and better investigative work.
We were taught that 5 to 10% of the patients had these problems, Kirk. I'm going to tell you today, I don't have any doubt it's between 50 to 60% of the general population in dentistry.
Really?
Yeah. I think you got about 20 to 25% who have centric relation, normal joints. You have 20 to 25% who have lateral pull, clicking, or locking, that the disc doesn't click. And then the other 50 to 60% is complete disc displacements. I can't remember the last lateral pull only case I saw in a growing patient.
Mm.
If kids are clicking, usually the disc is off. And if kids are clicking, if the disc is off, there's a greatly increased likelihood there's going to be some type of impact on growth, which is generally going to reflect as the class 2 occlusion.
Right.
So now the patient goes to the orthodontist. We send the patient to the orthodontist with the class 2 occlusion, and what do we expect 2 years later? We expect a beautiful class 1 occlusion to come back to our office. That's not the real world. We're hanging the orthodontist out to dry. We should never send a class 2 patient to an orthodontist unless we've diagnosed it first, because that way we can be an advocate for the orthodontist, not someone who has unrealistic expectations for the orthodontist. You know, the common question is, why doesn't the orthodontist image the class 2 patient to see if they have true centric relation? It's our responsibility to manage the occlusion. It's the orthodontist's responsibility to move the teeth. Now, someone has to do it. But honestly, it's going to put the orthodontist at a competitive disadvantage to the average orthodontist in their community, because now they're going to have to charge a fee for diagnostics, or they're going to not charge for it, which is going to cause a strain on their practice numbers.
Right.
it makes more sense for us to do it. We're the one who's going to see the patient long term. So
Okay.
that's I think the thought process on trying to bring this into a more mainstream thought process is start with the young kids.
Yeah. Okay. Go back to that. So if somebody's listening to this, they're like, Jim, you just threw me a big responsibility there. I mean, one of the questions I have is how do we know if CR is possible? And then the second thing is how do you start to screen for some of these injured joints?
Let's look at the languaging of that, Kirk.
Okay.
You said that I threw them a big responsibility.
Well, I'm playing devil's advocate here
I know.
because I have enough to worry about. I'm trying. And let me speak to the dentist who might be listening who's like, I really haven't had amazing education in this department. Do you know what
What
I
I-
mean? So,
But what I'm going to tell you is you are right. It is a responsibility, but it's our responsibility anyway, whether we acknowledge it or not. That's the
right,
first point.
right.
Number two, I'm going to look at it as an opportunity.
Love it.
We talked about this in the restorative diagnostic practice. If you can learn to do this, the number of patients who need diagnosis will keep your assistants busy on a regular basis. Now, this is the patient's best opportunity to get, I think, an accurate prognosis discussion about their treatment. So it is in the patient's best interest to do this procedure, and it's in our wheelhouse. This is our responsibility, whether we choose to accept it or not. It's our responsibility. So it's not as if we shouldn't be accepting this responsibility because it's already ours. We've already accepted it by the fact that we went to dental school. We're the ones in charge of the joint. We need to own it. No one talks about that point, but that is the reality.
Right.
You know what I mean?
I know exactly what you mean.
So that's, I think, the advantage because if you can do that, imagine how valuable you become to the orthodontist in your community.
Yeah.
Imagine who the orthodontist thinks about when they see the next class two occlusion. Well, I have to call Dr. Kirk because he was the one who was able to recognize the last one, and it made for a much better experience with the parents. And all of a sudden, your phone starts ringing a little bit more, and 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 it never stops.
Yeah.
I mean, that's what happens.
Those become some of the easiest patients you
Oh,
work with in your career. Wouldn't you agree? They
sure.
become highly referred. You do more of it, which means you get better at it, which means the word spreads.
It's it's a no-brainer. It's a no-brainer. But it all comes back to centric relation. Because we're intimidated by centric relation, that means we don't want to talk anything about the joints. If we understand centric relation, we can understand when we don't have centric relation, and then we can start to get a little better idea of what our options are. That's where the diagnosis becomes. So screening is really two things. Screening is history, and screening is looking at the bite. Those are the two ways to screen for this. They'll tell you. I've clicked and popped for 10 years. I clicked and popped since I was 12 years old, and then I stopped when I was 22. I had ortho because I had an overbite. I had teeth pulled when I had my braces. That means they weren't growing. I needed a palatal expander when I was 10. They're not growing. The likelihood is the disc is off since they were young. I've been clicking as long as I can remember. That's a pretty common one. So they'll tell you. The other thing is look at the bite. Check their bite in a normal, regular bite, and check their bite with the joints in the socket. You can use bimanual for that. You can use a leaf gauge. You can use an anterior deprogrammer that's taken down to the first point of contact. Any way you want to do it is fine. If you went to Dawson, you probably learned bimanual. That's what I did. If you went to Spear, you probably learned leaf gauge. If you went to John Coyce, you probably learned anterior deprogrammers. All different ways to do it. So, whatever way you choose to do it, look to see how the front teeth fit together. And then ask yourself one question. Has the patient had orthodontic treatment? Because if they have, that means the teeth aren't necessarily in the same place they normally would be. Does that make sense?
Does. It does.
So If they have had ortho, try and reverse engineer them back to see if you can figure out where the bite really fits together. That would be the way to think about those types of cases. And then look to see, are the teeth, well, the other thing you do then is put the incisal edges in the correct position. So if you've got a tooth that's tipped in like that, move it back to where it should be. And then simply read the bite, as Mark Piper used to say. Are the anterior teeth uncoupled greater than the thickness of the disc? If the answer is yes, I'm thinking I lost the gasket.
So I want to talk more about treatment, but before we cross that bridge, what else have we not covered about diagnosis that you think it's important for our listeners to hear?
Get an MRI and a CBCT.
Okay.
Get both. MRI is going to tell you some things. CBC is going to tell you other things. Create a bundled diagnostic fee, and then you can do this.
Yeah.
That's all it really comes down to, really.
Yeah.
Now, you have to create an imaging network. You can do that with an MRI center. You know, it'll take a little bit of work, but there's nothing that will bring high-quality patients into your practice faster.
Okay. I was going to ask you that question. Speak to the power and importance of imaging. Just go.
You never have to market again.
Right.
You never have to market again. And your phone calls come in the office as patients are referred from other dentists. So there's not a lot of discussion about yes or no. It's always, what do I have to do? They told me you're the person to come to. You do no marketing and people come in ready to do it. It's pretty amazing.
Right.
Now, not everyone does it, but the acceptance rate for diagnostic records is pretty high. And since you're generally going to have a lower exam fee and a higher diagnostic records fee, then that allows your practice to work so the numbers so it doesn't strain your practice to do this type of dentistry. Right. I guess that's the best way to say it. Because honestly, what happens is most of the time, you know, the old saying is you have to do restorative dentistry to feed your TMD addiction. Because the numbers don't work if you work at a usual and customary rate for your diagnostics. Right. It's too much time. You have to put too much time in these cases initially to figure them out to be able to understand what the treatment options are.
Yeah.
That's the reality.
Okay. So a couple questions. How do you treat patients who we can't achieve CR for?
Okay. You can't achieve CR. If they're pain free, I'm just going to treat them in a normal bite and we're going to do the best we can. So if I can get an occlusion that works, it may not be perfect, but I'll tell them that. I may have to use composite to pick up some contacts in a couple areas if things don't fit exactly. But if I can get a balanced occlusion and they seem to be comfortable and they seem to be working well, okay. The more the teeth are uncoupled usually means the greater the skeletal deficit. You know, we make this about the teeth because we're dentists. The reality is if the teeth don't fit, it's usually because the skeleton doesn't fit. That's the issue. The teeth are just the markers of the skeleton. They're just the ones delivering the bad news. Mm-hmm. It's the skeleton that doesn't fit. That's the issue. So if that's the case, then we have to think about what we can do to try and get the skeleton to fit together, or we get the best fit we can with the teeth and take it as it is. That's why you see bite appliances, because what that does, that gives us a way to bridge the gap with some type of removable appliance to try and help to protect the teeth when we can't get the skeletal bases to fit together the way we want them to.
It's amazing. Jim, any other thoughts? I have other thoughts. I got to be respectful of your time because I could keep you all day on this. Any other thoughts on treatment? I have three questions, three things. Let's talk about any other thoughts on treatment. Number two, I want you to talk about just wrap this whole conversation up. And number three, I know people are going to want to know more about how do I learn more about this? Where do I go? And I know you do a lot of teaching, but let's go in that direction. Last thoughts on treatment.
Treatment, easy. You have three treatment options. One is do nothing. Two is to do non-surgical options. If a patient has pain, you can do a bite appliance. You could do physical therapy or chiropractic if they have upper cervical spine. You could use anti-inflammatories and muscle relaxants from a pharmacologic perspective. You could use Botox on muscles. I don't personally do that, but it's a common thing that you'll see today. Those are all non-surgical options traditionally for pain. So my treatment planning really, I have a maxillary algorithm, but I'm not going to go through that now. The mandibular one is either surgical or non-surgical. Non-surgical are the options, typically a bite appliance, chiropractic or physical therapy, medications or pharmacology, and injections. Surgical would be soft tissue or hard tissue. Arthrocentesis and arthroscopies are putting, arthrocentesis puts two needles in the joints and flushes it. I've never had great success with it. I never worked with surgeons who had great success with it, so I don't have a lot I can report on that. Arthrocentesis is putting a camera in and maybe clipping some scar tissue. Used to be bigger in the 80s and 90s, but with MRIs and CT scans now we can see inside already. A disc repair is the only option that gets us back to normal. Now you have to have generally a younger patient. You have to have parents who are in tune. You have to have a sophisticated specialties team that you're working with. And you have to have soft tissue and hard tissue that haven't changed shape. If you can't do that, then you could think about replacement if you have good bone volume. If you don't have good volume, then you go to the hard tissue side. We used to do ribs as grafts to try and rebuild it. Today, artificial joints have come so far. The total joints now can be customized for each patient. So those would be your treatment options generally. Once that's done, then you go to the teeth. Frank Spear talked about facially generated treatment planning. Where does the central incisor go? What's the inclination of the teeth? Do you have level occlusal planes? Is the tissue in the right place? Bottom, do you have a level occlusal plane? Incisors in the right place? Do you have inclination correct? Do you have tissue in the right place? Steps are basically the same. Get the incisal edges, make sure they're inclined right, make sure they're level with the posteriors, and make sure the tissue, upper and lower. And then you take Pete Dawson's 4 Rs, reshape, reposition, restore, resect, and that's how you get there. That's a quick and dirty, if you think about it, combination of Piper, Spear, and Dawson kind of together for a treatment planning protocol that allows you to put them together as one.
Yeah. And maybe we can talk about the long video series that you created where people can learn more about that. Because I know you spent many, many days like shooting video to support all of this.
Stephen Phelan is out of Toronto, and Stephen called me, I don't know, last year, asked if I would do a module. Bob Margis was the one who gave him my name.
Yeah.
And I said yes, and it was a way bigger bite out of the apple than I ever thought it would be, but it's been a really cool experience. I just, 10 minutes before we got on today, I finished module 9. Wow. That was on literature. We reviewed 100 articles and 8 different topics. It was awesome. So Phelan Dental Seminars has an online program that I'm doing, TMD Online. It's 10 modules. And then we have bonus modules with Brian Shaw, who's an oral surgeon, Tom Preddy, who's a radiologist, Drew McDonald, who you mentioned before, an orthodontist, Seth Atkins in digital dentistry. It's an awesome program. If you're looking for that, Stephen Phelan can give you that. I do teach at Spear. I teach advanced occlusion workshop, and I teach the occlusion seminar. The occlusion seminar is with Frank Spear, with Greg Kinzer and myself. We just did one in Boston. It was we had 250 people. It was an awesome course. It was really a neat experience. The advanced occlusion workshop is a smaller group. There's one next July at Spear. I do that myself. I have Seth Atkins comes out and helps for that. We have a digital component to it too. That's an awesome 3 days if you want a hands-on experience in this. Chicago Study Club is something that I run with Kurt Ringhofer, Seth Atkins, and Drew McDonald. That's twice a year in Chicago. That's by invitation only. If you want more information, Kurt can give you my contact and we can talk. Um, I think that might be it, Kirk.
Yeah. And I was hoping you would say all that because I was going to prompt you to list all this. Now, I know that's a lot of information, but this is how it works here in the Best Practices Show. If you weren't taking notes when you were listening, don't worry. We're taking notes for you so you can flip up to the notes wherever you're consuming this podcast, and you're going to see links to Stephen Phelan's course with Jim, or if it isn't published yet, we'll put a link there. Also, all the courses you listed at Spear, and then a little bit about Jim's study club, which I'll highly recommend. If this is something you want to be a part of, you're going to surround yourself with the best. So give us some final thoughts, the final thoughts on centric relation today as we wrap this up.
I'm hoping it's not as misunderstood as it was when we started. Centric relation is normal joints and normal joint sockets. If you have it, you have advantages. If you don't have it, then you got to see what the anatomy looks like so you can have a realistic idea of what to talk to the patient about. That's it. It's really about predictability. It gives you confidence when you're treatment planning. So I think you talk to patients differently. Patients hear that. So I think it's an invaluable tool to understand the concept. And I think that, yeah, there's maybe some misconceptions about it. But if you understand the topic, your confidence level in treatment planning is really going to increase. And you'll notice that in your case acceptance. That would be my final.
So well said. Jim, you're the best. I really, really appreciate this. And I know our listeners do too. So thank you for being on today, buddy.
Always great to be with you, Kirk. Thanks so much.
We're going to cover a ton more of the subjects I want to cover with Jim here in the future, and you'll see we'll line those up. So stick around while we say goodbye to everybody else. But thank you guys for listening to the Best Practices Show podcast. You can see why I enjoy this so much. Being surrounded with some of the best minds in dentistry, it just lights your fire, gets you super excited. So I hope you guys enjoyed today. Check out the links that Jim mentioned down in the show notes. I promise you won't be disappointed. It'll give you some great education from some of the top minds in all of dentistry. And keep sending us suggestions for things you guys want to see. We're lining them up all the time. So until we see you guys next time, or you hear from us next time, keep watching or keep listening to the Best Practices Show. You guys enjoy your day.